Hello and welcome. I'm Susie Durie, President and co-founder of the International Myeloma Foundation. It's my pleasure to welcome you to this webinar, Best of ASH 2021, What Patients and Caregivers Need to Know. And I think we all need to know everything as soon as possible. ASH is the annual meeting of the American Society of Hematology. Like everything else this year, ASH was virtual. However, it was still chock full of clinical trial updates and data. This evening, Dr. Brian Durie will discuss key takeaways from the annual conference specific to myeloma and explain how this new and important information relates to all of you. If you have not yet accessed tonight's slides, you can do so at www.myeloma.org. Additionally, to help you better understand some of tonight's slides, we have included links to myeloma terms and definitions, and also myeloma acronyms commonly used. You can find these links right now below the button where you downloaded tonight's slides. At the end of Dr. Durie's presentation, we will have time for your questions. I'd like to take this moment to thank our sponsors for the support of tonight's call, including Amgen, Bristol Myers Squibb, GlaxoSmithKline, Janssen Oncology, Karyopharm Therapeutics, Oncopeptides, Sanofi, Genzyme, and Takeda Oncology. It's really amazing. When I first started, there was like 2 companies that we worked with, and now it's wonderful to see all these companies out there. It's now my pleasure to turn this call over to Dr. Brian Durie.
Well, thank you so much, Susie, for that kind introduction. We are obviously very grateful for our sponsors, and I'm glad to have this opportunity to review what happened at ASH. And as you emphasized, Susie, the main thing is, what are the takeaways? How does that information influence our choices in treatment options as we move through 2021 and forward from there? And so on slide number 3, I've just summarized the areas where I'm going to touch on tonight: smoldering myeloma, frontline therapy, early relapse, focusing on treatment options, obviously the new immune therapies, and future directions, which, as I mentioned a moment ago, under that I will touch on the situation with COVID-19 and some of the very important questions that have been coming in actually ahead of this telecon today. One last point. Can you hear me well? Just to be clear, is my audio coming through strongly?
I can hear you fine.
Okay, just to be sure. All right. And the other thing is that I can see questions coming into the chat box, and so to the extent that I can, I will answer questions as I go through. So if I'm on a topic and you have a question, it may be that I'll be able to get to it just right at that moment. So I'll certainly try to do that. So on slide number 4, the virtual ASH this year had 688 abstracts on myeloma. 179 of those were oral, 500 posters. The total ASH abstracts were down a little bit this year from usual. Not really sure why, but obviously a very difficult and complicated year. So smoldering myeloma, this is still a very, very important topic where a lot of questions continue, mostly from people who have MGUS or smoldering myeloma and are anxious to know whether it's appropriate to be looking at getting started with treatment. And so we have a few times as part of ASH, we did this as part of our satellite symposium, for example. Vincent Rajkumar on slide number 6, he reviewed when is it that treatment should be started. Well, obviously, if you have active myeloma with CRAB features, that's pretty clear. If you have elevated calcium, kidney problems, anemia, or bone lesions. We've also expanded that to include what we call myeloma-defining events, where there's a high percentage of plasma cells in the bone marrow, more than 60%, an elevated free light ratio above 100, and more than one focal lesion on MRI or potentially other kinds of imaging. So that's clear. But what's not so clear is that if you have some abnormal findings which are less than that, which are not myeloma defining events, when should we really be just observing, and when should we be thinking about starting treatment, either within a trial or possibly even outside of a trial, which is one of the topics that was discussed at ASH this year. So the IMWG conducted a large study this past year, actually over the past 2 years, where we came up with a risk score to predict if patients with smoldering disease, something less than myeloma defining events, are at risk of having progression and whether maybe treatment should be started. And so on this particular slide, number 7, you can see the main factors which are helpful in predicting this risk. The free light FLC ratio, free light ratio, the level of the myeloma protein, the bone marrow plasma cell percentage, and whether or not there are high-risk features on chromosome fish testing. And you can see right in the middle the graphs of the different groups. It's possible using those risk factors to come up with a group of patients who are at higher risk, who are likely to progress within 2 years. And so that purple graph, the one at the top, there is a 72.6% chance of progression in that group of patients, a group of 51 patients. 37 out of those 51 patients actually progressed. But one of the really important things that came out of this analysis is the bottom graph, the red graph at the bottom, the low risk group. And so there were 241 patients in that low risk group where the FLC ratio, the M protein, the bone marrow percentage was low in those patients. And the risk of progression at 2 years was only 3.7%. So a very, very low risk of progression. And so this is extremely important. If you happen to fall into that group, then you can breathe a sigh of relief in the short term that really it's unlikely that things will change and that treatment might be indicated. And in between, there are these intermediate groups. So to fall into those, I would just point out, when you look at the scoring system, one of the more important things is if you look at the BMPC percentage on the left, you'll see that when it's low, you have a 0, and then it goes to 2, 3, 4, 5, 6. And you can see that you can get to a number 6 if the percentage goes to 40%. And so actually, the main thing that drives the need for possibly thinking about treatment is that percentage of bone marrow cells in the bone marrow, the plasma cells in the bone marrow. 20 to 30%, you get a score of 3, 30 to 40%, you get a score of 5. And so that is a main thing to look at. Conversely, if you look at how high is the protein level, if it's above 3, you just get 4 points. And so it's not the main thing that is driving the risk in this setting. So this is a helpful thing, and we have an app which will be released soon where you can load in your numbers and it will give you your score, which you should then obviously talk to your doctor about to see how everything is looking. But the main thing which was represented at ASH is that we do know that using Lendex versus observation is helpful. And so this is a study with a follow-up of over 10 years now, median follow-up of 10.8 years on slide number 8. If you took Lendex, you do much better versus just observing if you're in this high-risk group. So this gives us what we call a proof of principle that early treatment is beneficial. But I would draw attention to the fact that with Lendex, the median overall survival is 6.4 years. And so as you'll see with all of the results that I'm going to show you, this is excellent and better than having done nothing. But the big question now is, what if we give a stronger treatment? Maybe we could do a whole lot better. And so what is recommended as therapy possibly for high-risk smoldering? So first of all, in the low-risk group, for sure, observation. If you're in one of the intermediate groups, you certainly could consider something like Rev-Dex. But to be aware, this is not a really decisive treatment necessarily, and would be mostly more targeting prevention of progression. But if it's really in a higher risk situation, more like myeloma therapy is something to be considered, either from your doctor or within a trial setting. And right now, there's a large ECOG trial where RD is being compared with VRD to see the added benefit with VRD versus RD. And of course, through our Black Swan project, we have conducted 2 cure type trials where we've used Kyprolis Rev-Dex plus transplant, and we're using daratumumab KRD with or without transplant. And so those have produced really dramatic benefit, with over 60% of the patients achieving an MRD negative status. And so it is quite promising that if you start early and you use decisive therapy, you can really have an excellent outcome. So this leads straight into frontline therapy, because basically the way that we're approaching these early patients is very similar now to the way that we're approaching frontline therapy overall. And so if you're newly diagnosed, the big thing that we still look at on slide number 11 is, are you eligible or able or wanting to have a transplant or not? And so we put not transplant candidate, possibly related to age or maybe choice. And so the big news there is, number one, over the past 2 years, we have seen really excellent results with DRD, which is daratumumab Rev-Dex. And this was the Maya trial, and I'm going to show you that in more detail in a minute. But you can also use VRD, VRD Light. There are several of those modified regimens, or you could use VMP Dara or RD. And so I'll talk about that first, and then take a look at, well, what are the options for transplant patients? And there, the standard of care is clearly VRD plus or minus daratumumab to give a 4-drug combination. And I'm going to talk a little bit about the pros and cons of that. And if Revlimid is not available, then thalidomide or even Cytoxan can be used. And then I'm going to talk about some details of transplant, the value of that, and what to consider for maintenance. So if we look at patients who are not eligible for autologous stem cell transplant, ASCT, a number of trials have been done, but the greatest interest stemmed from the bottom trial, the one which is called Maya, with daratumumab Rev-Dex, where the remission was excellent in the 3 to 4 year range, and the overall survival excellent compared to other regimens. Results actually rather similar to the SWOG trial, which I conducted with VRD, where the PFS, the remission duration, and the overall survival actually rather similar. This was updated by Dr. Shaji Kumar at ASH, and he showed that if you look at 4 years, 60% of the patients are still in remission. And so this means that the average remission, or PFS, could actually be in the 4.5 year range. And so this is quite important and is linked to another kind of a trend right now, because this is influenced by the fact that patients continue to take DARA along with the RD. So the maintenance includes the DARA. So it's not just like a Revlimid maintenance. There's also ongoing DARA once a month. So this is something that is being looked at now in terms of, well, maybe take DARA as maintenance, maybe, as I'll show you in a minute, include even Kyprolis or something, Velcade, which is difficult to continue, but to think about these different additional options. So one very important study that was presented at ASH this year was the Fourday trial, which is for transplant eligible multiple myeloma patients. And this is kind of a complicated trial. And in this trial, they looked at whether the patients had a stringent complete remission and even became MRD negative. Now, this trial was actually designed by Antonio Palumbo, and at the time people thought it was pretty crazy and too complicated, and we weren't sure what we would get out of it. But actually, as it has matured, the choices of the KRD with or without that single autologous stem cell transplant, the big block in the middle, and then whether or not you get more KRD after that, versus just staying on KRD, the big green boxes at the bottom, KRD, 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 12 rounds of that, 3 times 4, and then whether you get Revlimid or KR, Kyprolis, Revlimid as maintenance. And so it turns out that there were a few quite important lessons that came from that. One of the first ones was that whether you measured the MRD by flow MFC or by next generation sequencing, the benefit with the MRD negative patients was the same. And so the important conclusions from this large study was that it didn't matter which method you used to check the MRD. If you were negative at the 10 to the -5 level, then that was good. The next thing is that if you had KRD and the autologous stem cell transplant, there was a higher percentage of patients who had not just MRD, but sustained the MRD for at least a year. One really important point was that the main thing was to get to that MRD negative level, whether that be with or without transplant. If you got to that MRD negative level, it was independent of the treatment. In the maintenance phase, using the Kyprolis as an ongoing part of the maintenance did increase the achievement of MRD negative. So a number of quite important points came out of this study. Now, in contrast to that, we did have an update at ASH of the French trial, the IFM trial, which is VRD with or without upfront transplant. And this has been presented a few times, and the results are actually pretty clear. In terms of the remission, the progression-free survival, PFS, the patients who get the RVD or the VRD with transplant have a longer first remission. You can see that they are 47.3 months versus 35 months, about a 1-year difference. And this is consistent in terms of what we've seen for some time. However, if you look at the overall survival in these patients, it remains exactly the same. And so this is a bit confusing. And part of it is that the patients who were not transplanted up front, a significant percentage of them actually did get transplanted later. And so that may be the reason that we're not seeing that broad benefit in one arm versus the other. But what is clear is that no matter the treatment, whether it be transplant in red here or without transplant in blue, the patients who achieved MRD negative did better. So it's the same message. No matter how you get there, if you get that deep response, that is what is the important thing to get that greater benefit. And so this is really the theme in the frontline setting, especially in the transplant eligible patients. And so I'm not going to go through all of the data, The Griffin trial was also presented at ASH, in which patients received daratumumab with BRD. And again, there was an increase in MRD negativity. And so this has really introduced the notion that Dara BRD could well become our new standard of care in the frontline setting, although we need some additional trial data to show that full benefit. So if we move forward to the relapse setting, I think quite a lot of data presented at ASH. I think that in first relapse, so many different options. The key thing is that most patients who relapse early will have received lenalidomide, Revlimid. And so the question is, how do you handle a situation where a patient is refractory to lenalidomide? So if perchance you've had it, but you're not refractory, then obviously you can get a combination that still includes the Revlimid, and that could certainly be the Maya regimen, the Dara RD, or it could be with Kyprolis, ixatuximab, or elotuzumab, or it could be an IMiD-free regimen, like the Candor regimen, which is KD Dara or KD ISA could be used. If you are definitely refractory to lenalidomide, then you need to move away to use something like pomalidomide or an IMiD-free regimen. And we've provided a summary of all the different options, which I can't go over now, but you can see here clearly this is an important moment, and right now it may be that you need to have a video conference with your doctor to chat about some of these options and see what is the best in your particular case. But the big topic at ASH this year, and as it had been in the last couple of years really, was what about all of the new immune therapies? And so those have been tested in what's called triple class refractory, and this is in patients who have received an IMiD like Revlimid or pomalidomide, a proteasome inhibitor, which would be like Velcade or Kyprolis, and also daratumumab. So when all else fails, these are things that can be considered. And so this slide here summarizes in blue, there are a number of treatment options where they've been approved already by the FDA, most notably Benref, which is belantamab, which is an antibody with a drug conjugate, which is mafodotin, and then obviously selinexor, either alone or in combination with Velcade Dex, for example. And then over on the right, all of this vast array of new agents that were presented at ASH this year. New monoclonal antibodies, the new CELMoDs, the bispecific antibodies, which I'll talk about, and then the cellular therapies where we're talking about the CAR T-cell therapies. And so many of these in development, and I'm going to touch on the ones that were presented and the ones that are moving most quickly forward. And so for the CAR T cells, the one product was used in the CARTITUDE-1 trial. And this is the product from the Janssen company and has been presented a couple of times and was presented again this year by Dr. Deepu Maduri from New York, who did a nice job giving an update of this CARTITUDE trial. And so obviously with the CAR T cells, these are manufactured. And so this is not an off-the-shelf product. This is something where the cells are harvested, they're engineered so that the T cells will attack the myeloma, specifically attacking the BCMA, the B cell maturation antibody, which is on the surface of the myeloma. And so this has proved to be a very active approach. And with this CARTITUDE study, these engineered T cells, it's a one-time infusion by and large, where you give these CAR T cells. You manufacture them, and then you bring them back, and they're given IV, and then you can see a very high overall response rate, ORR, and you can see the big blue box where it's at least a very good partial response. So deep responses, and with MRD negative stringent complete remissions being achieved. So very active with deep responses, and the safety profile was manageable. There were definitely some patients with complications, and there was some discussion of some patients who even died with different problems during or after the therapies. But clearly, durable responses in heavily treated patients, and such that this product is already being investigated in other disease settings. So very promising, and they have a fast track basis with the FDA, and so these data will, I think, be submitted to the FDA at some point this year. Running a little bit ahead of this product is the BMS Celgene product, IDACEL, which we've called BB2121 for the last several years. And so we've had quite a number of presentations with this CAR T product, again, manufactured to attack BCMA on the surface of the myeloma. And this produces excellent responses. What this chart here shows is that if you go from left to right, you can see the bars get taller, and this is because there is a dose response. And so with this product, there's definitely more benefit with the higher doses of the product. Overall, the orange, kind of orangey red bar at the top indicates that around a third of the patients, 30-some% of the patients, have these deep responses. So fairly similar to the CARTITUDE. And so again, you have this amazing product which is producing deep responses in patients with refractory disease. And so this is excellent. And the remission durations have been in a year, or in this case, maybe a little bit less than a year. But I'll draw attention to the fact that the overall survival, the average overall survival is actually is 19.4 months, but it's moving out towards 2 years. And so the interesting thing is that even patients who may have not had a full remission or even respond and have some relapse, they can continue to have to do well, and this is being investigated to understand what therapies can work and keep things going, even although the initial full remission may not be 100% sustained. Again, these KARMA trials 2, 3, 4 indicate that this product is being used in earlier disease settings. For example, patients with high-risk myeloma, where there's an unmet need to find therapy that will work well for patients who have high risk and who are at higher risk to relapse early with VRD or even VRD-DARA perhaps. One very, very interesting new topic that was presented by the group from Dana-Farber is what about if the BCMA is lost from the surface of the myeloma? And so this group studied patients where actually the BCMA was lost, and what they found was they documented what they call biallelic loss. So what that means is that you have the 2 chromosomes that have the BCMA to express, and to have a loss, you need to lose both, so biallelic. So both of them were lost, and this is located on chromosome number 16p, which means it's on the top of the chromosome. And then what they found was that that actually one of the BCMA genes was actually lost, but the other one was actually not lost, but was mutated, so it wasn't working well. And so what this means is that to evaluate this on an ongoing basis, careful molecular testing is going to be required to assess the frequency and the importance of this type of thing, where obviously if you've lost the BCMA, then the BCMA therapies are not going to work. And so what are other approaches to be used? Tremendous interest in bispecific antibodies. And so what this means is that you have an antibody with two arms. One arm grabs the myeloma, and in most instances right now, that is again grabbing the BCMA. The other arm of the antibody grabs the T cells, CD3 on the T cells. And so it brings the T cells close to the myeloma to help with the killing of the myeloma. And so this is obviously great. Obviously, you do need to have T cells which are working well. And so this is a key thing where late in the disease, those T cells may not be perfect. And this is certainly something that will influence the value of this kind of therapy, especially later in the disease, and maybe a little bit earlier, there could be enhanced value. So a lot of results presented at ASH. This particular abstract, number 180, an agent called Teclistemab, BCMA, and then CD3. So the two arms bringing the T cells close to the myeloma cells that have the BCMA. Again, you have high responses with this, maybe a little bit less than the CAR T cells, 73%. You can see this dose response pattern similar to the BB2121 CAR T situation. Dose response quite effective, and overall it was well tolerated. One disadvantage to this is that it's an ongoing treatment, either IV or sub-Q, like once a week. So this is an ongoing treatment, and the initial therapy, most likely right now, seems to be in the hospital to get started with this, just to make sure things are going okay. But quite promising early results, and this is an off-the-shelf product. In other words, there's no personalized manufacturing involved, and so it is immediately available. So quite encouraging. Another bispecific, a new one, where the target is not the BCMA, but a new target called G protein coupled receptor family C group 5. Now there's a mouthful. GPRC5D. So this is encouraging because, as you'll see in a second, it does work well, and it's an alternate. So if BCMA has been used before, this could be a backup using a new target. And so this just shows you the details of the loops that are expressed and are the target for the bispecific antibody. Interestingly enough, this target is shared by hair follicles, and so there's some toxicity for the skin and hair follicles with this particular bispecific, kind of a new toxicity. But again, these patterns are getting to be very similar, where you have these responses going up into the 60–70% range with a dose response, and with deep responses also, possibly not as many as deep responses as you see with the CAR T cells, but again, very respectable responses. And it was tolerable as administered. Again, this one was given subcutaneously weekly, high response rate, and we just need to get more data on these to see how things proceed with more patients and with longer follow-up. And so this brings us to a little bit of a discussion point here. We have the CAR T cells, you've got the bispecifics, and then you also have the belantamab, which is the drug conjugate. So the Bela and the bispecifics are off the shelf. The CAR T cells need to be manufactured. So that's a big difference. The CAR T cells are what they call one and done. There's just a single infusion. With the others, it is ongoing therapy. So that's an inconvenience there. With the belantamab, the main concern has been some toxicity with the eyes, what we call keratopathy, and so careful eye monitoring, checking of the eyes is required with that to adjust the dose or delay the dose if necessary. But the big thing with the CAR T cells is dramatically active. However, you do need to go to a specialized center with skill in managing the potential cytokine release syndrome and some of the brain or neurotoxicities. And there's a significant support and attention required to get patients through CAR T cell therapies, which can be done, but not necessarily at every center. Conversely, with bispecifics, this should be broadly available, and we just need to see what will be the overall impact. So where does this put us in terms of future directions? Well, I think that as I was preparing for this presentation today, questions were coming in by email about COVID-19, and I think that this is very, very much on everyone's mind. How does COVID-19 impact our choices, impact our treatment, impact a variety of things that we might or need to do? And so top of everyone's mind right now is vaccination. And so I would just say that using the Pfizer and the Moderna vaccines, which are the two currently available in the US, both are highly effective and the results seem to be very, very much equivalent. So either one, if it's available to you, would be an acceptable option. Are there situations where it's not a good idea to take it? Not really, not too many. You should talk to your doctor for sure. If you've recently had an autologous stem cell transplant, I think most people agree, at least in the first couple of months or so, it's probably not a good idea to have your COVID vaccine right then. If you're receiving ongoing therapy, I would just say it's not a great idea to take your DARA shot and the vaccine on the same day. I would say that space it out a bit. I mean, if you're on DARA, for example, maybe tee it up so that you would get your vaccination before you're scheduled for your next, to start your next DARA treatment, for example. Ongoing maintenance with Revlimid, that does seem to be safe, and I don't think that there's a need to stop maintenance. So I think that that's good news. There have been quite a lot of questions about dexamethasone. Dexamethasone does seem to be helpful in patients who develop COVID-19 pneumonia and become short of breath or have difficulties, but it's not necessarily helpful outside of that situation. And so it's not a good idea to be taking lots of extra dexamethasone like as a preventative. However, if a myeloma patient does have lung issues, then dexamethasone is definitely indicated and would obviously be also helpful for the myeloma. I would just say that if a COVID-19 test does come back positive, the main thing I would emphasize is encourage your doctor to get a chest CT scan for you to make sure if you do or do not have some early pneumonia, because that is especially important for myeloma patients. And you might want to get a pulse oximeter, which you can get at the drugstore, to monitor your oxygen levels, just to make sure that there's nothing early happening with your lungs where you might need to take dexamethasone or maybe get further attention. And so I'm happy to take what could be maybe a number of additional questions about COVID-19, okay? So as far as other kinds of therapies moving forward, I've touched on the first relapse, additional options. I've talked about the Bella. I'll touch a little bit more on selinexor. One thing to mention is that cyclophosphamide, which is a alkylating agent similar to melphalan, is something that can be helpful as part of a combination to make therapies work better. At ASH, the follow-up of the Candor study was presented, and clearly a very, very active regimen, IMiD-free, active, with or without Revlimid resistance, but certainly if prior Revlimid exposure, carfilzomib, Dara-Dex, more active than without the Dara, and active across the board, which is what it shows here. So this is an important new option for patients. And then with selinexor, the updates of the Boston trial were presented, and clearly in this case, selinexor Velcade-Dex superior to Velcade-Dex, and so with some quite nice data. And in fact, for those of you interested, the Boston trial data have actually been published. The selinexor bortezomib-dex. We have also published a paper with management guidelines for the selinexor. As you probably are aware, it's not the easiest drug to manage the side effects, and so it's quite important to spend some time talking to your doctor about some of these details before you launch off in a selinexor treatment program. And then we do have a manuscript that helps guide in that respect. So some of the other things that were discussed, going beyond IMiDs, we have the CELMoDs, which target the same sort of IMiD type pathway, and there's a couple of those in trials. The first one is the iberdomide, where the data are quite good, showing results in patients who have been refractory. There's another one coming along, CC92480, which may be actually even more effective, it seems. And so we get to what is the future state, and this is just a summary for people who maybe have gone through a lot of different therapies. And so if you've taken an IMiD, a proteasome inhibitor, and Dara or isatuximab, you know, what kinds of things are you looking at? And the main thing on this slide is in the light blue box, we're mostly focused on anti-BCMA strategies, which can be belantamab, which is the ADC, which is the drug conjugate, or it can be a bispecific, which are currently just in trials, the Teclistemab, for example, or one of the CAR-Ts. On the dark blue box, I would just mention that this drug cyclophosphamide, which is an alkylating agent, in combination with some of the other agents, can give added benefit. And so we've kind of shifted back to consider that as an important option to consider, to not forget about using cyclophosphamide, which can be by mouth or IV. And then over on the right, if you have really gone through those BCMA and the Cytoxan options, we are really looking at the light blue box there for the new drugs, new monoclonals, the CELMoDs, new bispecifics using a new target, for example, new CAR-Ts, of which there are many in development. And of course, we do have the existing drugs, elotuzumab. It's been encouraging to see, for example, that elotuzumab, pomalidomide, and dex, that triple combo, a relapse regimen, can be active even in patients who've gone through BCMA therapies. And then, of course, you have the selinexor combinations. Venetoclax, especially for consideration in patients who have the 11-14 chromosome abnormality. And then the panobinostat and bendamustine and the BTD pace, which is something to use to get control of dramatically relapsing disease. And so I've gone quickly through a lot of different topics, but I intentionally set it up so that there would hopefully be enough time to go through whatever questions you might have. So thank you for your attention. I hope that you found this rapid zip through ASH and what the current situation is helpful. So I'm seeing a number of questions in the chat box here, and I can see that there's a question about a plasmacytoma. I think that the new immune therapies have been active in patients with plasmacytomas. So that is definitely some good news there. Yes, I see one question here, which is an important one. Are MGUS or smoldering myeloma patients considered immune compromised? So in studies coming out of Iceland, we found that actually those patients do not seem to be particularly predisposed to get COVID-19 infection, and so their likelihood of getting COVID-19 infected was the same as the general population. And then in addition, the outcomes were also the same as the general population, influenced really only by age and coexisting risk factors, the same as the general population. Yeah. Yes, so I'm just seeing if there's any other things that would be broadly interesting. But can we open up the audio to take questions? Can we do that? No, we can't do that. Okay, so this is the only vehicle for your questions. Yeah, we could certainly, we have all of these questions as they're coming in, and what I can definitely do, and I'm planning to do it for one of the other programs, is to do like a podcast where I'll take these questions and just do a podcast where I'll run through and touch on a number of these questions, which are obviously quite important. So here's a question. At ASH, there was a lot of buzz on precision medicine approaching use with venetoclax for 1114. Right, and so precision medicine, I mean, it is buzz is probably the correct word. I mean, it's a buzzword where really we don't do a whole lot right now. Venetoclax definitely is active in patients with the 1114, especially if they have increased production of this BCLA. Unfortunately, the Bellini trial, where this was evaluated, has some problems, and where they included patients with and without the 1114, and the patients who did not have the 1114 actually did not do so well with the venetoclax. And so there was a bit of anxiety about side effects with venetoclax, but it is a striking example where if you do have the 1114, this is commercially available, and so it is something that your doctor can consider to use as part of a combination. And in fact, we are starting a trial to further evaluate this. It just really is unfortunate that the trials got really delayed when the results of the Bellini study came out. And so moving on to a next question, a newly diagnosed patient can a newly diagnosed patient get immune or specific antibodies as a first treatment, or only if they've had chemo and autologous stem cell transplant? No, right now, a patient can get in a non-transplant patient, for example, the Maya regimen can be used, DARA, Teclistemab, Revlimid, and Dex, so in a transplant patient, Velcade Revdex is still the standard of care. In high-risk patients, we might consider Kyprolis Revdex. However, your doctor does have the option to consider adding in the daratumumab, which is what we saw benefit with in the Griffin protocol that was presented at ASH. We know that DARA BRD is very active, and so your doctor has the option to consider that if it could be covered through your insurance. And if obviously 4 drugs is more challenging than 3 drugs, but it's certainly an option to consider. Okay. Right, there's a question here. Is COVID vaccine impacted by pomalidomide? Unfortunately, we don't have clear information about the particular impact of therapies on the vaccine, and so I think that we may learn a little bit about that over time. My personal perspective is that some of these therapies could possibly reduce the COVID-19 antibody levels which are generated to a variable extent, which we will find out later. However, that doesn't mean that you shouldn't get the vaccine. So I think that I broadly recommend it's so important to get the vaccine. And so with the first dose, you get your protection up to 50 to the 65% level. And so that seems to make a huge difference in any impact of a COVID-19 infection. And so even with sort of a suboptimal value from the vaccine, it's still going to give you important protection. And so we may learn over time that myeloma patients need to get an extra booster vaccine to get to a higher level, but that should not stop people from getting vaccinated right now. And you've probably seen the discussion in the news where people are saying, look, let's get everyone to have that first shot so that we can have a broad 50 to 65% level of protection, which will be so helpful in slowing the current spread that is so endangering many of our communities right now. Obviously, it's fantastic to get up to 95%, but if we can really reduce the spread, let's get started with that and then push to those higher levels, which may be necessary for some myeloma patients because of the reduced antibody responses. But we'll learn that over time and do our best to boost as best possible. Yeah. I understand that these are anxious times, where patients are uncertain what will be the full benefit of the vaccine in their case, and we just need to go with let's get vaccinated and try to move forward with that. I'm looking at some of the other questions. A lot of different questions here. There's a question which I haven't seen. Well, actually, this is a question coming from Jack Aiello. So Jack, a patient asked about a recommendation to use Panabisad Velcade combination. And as you say, Jack, this is not a combination that we've used a whole lot. I mean, it is a valid option, and the problem was with the side effects. It's a difficult drug to use. and really reduces the blood counts, especially the platelet levels, and has a lot of GI toxicities, which were really difficult for patients. And so it's not an easy combination, and I think it's fallen out of favor because we do have so many other different exciting options. You know, maybe there could be a chance to get into like a Selmoid trial, or, you know, a melflufen trial, or, you know, so many of these different new therapies. By the way, I haven't had a chance to talk about all of the new therapies, and we do have listings of those. I've just touched on the ones which were most prominently discussed at ASH, although most were touched on even a little bit. There's a question here, which is that if you go through a stem cell transplant, does that limit your future options? And so the answer to that is absolutely not. You know, these days, the majority of patients will have excellent recovery of their blood counts, and so it doesn't really limit different options moving forward. So that's an important point. Yeah. When will the Smouldering Myeloma app be ready? We're looking to launch that pretty soon. It is actually set up. We have a new graph that we want to make it simpler to interpret, and so we've just delayed to put that in there. But we should be able to launch that within, well, certainly within the next month, within a week or two or three. And we wanted also to have good guidance so that patients would be teed up to talk to your doctor about it. And so there's a question here: can you take I guess the pneumovax at the same time as the COVID-19? Yeah, probably. I mean, but logistically, right now, what's happening? I mean, there's such a stress on the system to get the COVID-19. You know, I would just focus on getting the COVID-19 for the time being. And I'm looking here. Should we take Dex when we're doing the COVID vaccine? Again, similar to what I was saying a little bit ago, I would not take Dex on the same day as if you're taking the 1 day a week Dex, don't do that the same day as you get your vaccination. It just could reduce the that immediate benefit. Another question here: is an allotransplant still an option? I didn't talk about that. It is still an option that we have not used a lot. We still do consider it an option in patients with high risk myeloma, where we basically have an unmet need. And in Europe, I would say it's more frequently used because they have a study done in Europe where they did show a little bit more value than was evident in the large US trial, which actually did not show clear value with the allotransplant. But it's definitely a backup option, and I think that we would all look at it, particularly in a patient with chromosome 17p minus or 1q or some of the high-risk chromosome abnormalities. What is the protocol for maintenance treatment for high-risk myeloma achieving MRD negative, and how long? Okay, so if you have high-risk myeloma, we would tend to use not just Revlimid, but we would use Revlimid plus a proteasome inhibitor. Traditionally, we would use Velcade twice a month. However, in the recent study, the Fourday study, using Kyprolis as part of the maintenance did seem to be helpful. And another option would be to use daratumumab as part of the maintenance. Although I would say there is a small caveat with high risk myeloma, where the one group of patients that didn't have such a dramatic benefit with the Myo regimen were the high risk patients. But nonetheless, we would use something more than just Revlimid, that's for sure. Did I understand correctly that a quad regimen for Frontline is showing best results? That is correct. In the Griffin trial, there's a higher level of response, achievement of MRD negative with DARA VRD versus VRD. And so based on what we know, this could well be moving towards a new standard of care since this was a well tolerated regimen. The Griffin study was not structured as a trial that would lead immediately to a standard of care option. But I think that here in 2021, I think many of the treating doctors are certainly looking at the Four drug as a way to get the best results. I think we talked about that one.
So Dr. Durie, we're getting close to time. It's about 8 o'clock now, and I know
Absolutely.
that there are so many questions in the box, which is good.
Yeah, which is excellent. So forgive me if I didn't touch on your particular question. I was scrolling down and trying to do the best that I could to cover different kinds of topics that could be of interest. I'll just mention one last thing, which is that there still is some increased risk with Revlimid in the maintenance setting, but that it's a relatively low risk, and it's not been an issue that has been really at the forefront in the last 2 or 3 years. I would say much more value with the maintenance versus that lower level risk, possibly with a risk of a second cancer. So we're aware of it, but it's not such a big issue. So I'll turn it back over to Robin and Susie if you guys want to wrap up and have any final thoughts or comments.
Susie?
Oh, Susie's still there.
Hello?
Oh, there you are. Are you still there?
Yes, I was muted to be quiet.
Oh, that was very good. So any final thoughts or comments?
Well, first of all, I'd like to thank you, Dr. Durie, and I'd like to remind our participants that the IMF will continue to provide educational programs virtually. I know it's much more fun when we can all get together, but this is the next best thing. So stay tuned for upcoming dates and patient and family webinars and regional community workshops. I've been having a lot of people coming to me and saying, I want to have a workshop. I want to get out of my house. So we're really going to work towards that. And all support groups continue to meet virtually to stay safe, which is very important, and stay informed and empowered. So please contact Robin Toohey for details. Additionally, don't forget that March is Myeloma Action Month. Even though we've probably all been in our houses, we can make it very active. We have many programs planned to increase awareness for this entire global myeloma community to participate in. Watch for more on our website, myeloma.org. The replay of this teleconference will be available early next week, and you can access this and all previous IMF webinars at Myeloma and click on IMF videos. Last but not least, if you have any questions, the IMF info line has answers. That toll-free number, again, the toll-free number is 800-452-CURE, which is 2873. So again, 800-452-2873. And Missy, Judy, and Paul are happy to take your calls. They're available Monday through Friday, 9 to 4 Pacific time. And once again, thank you to Dr. Durie, and a very special thank you to our sponsors that continue to make these valuable calls possible. Amgen, Bristol Myers Squibb, GlaxoSmithKline, Janssen Oncology, Karyopharm Therapeutics, Oncopeptides, Sanofi Genzyme, Takeda Oncology, and the best bottles of wine we can all drink.
So
And
thank yeah.
I just stuck that in there. And most importantly, thanks to all of you for taking the time to be on this call. We hope you found this helpful to stay informed and to continue your important conversations with your healthcare team. So have a wonderful evening, and we wish you a safe and happy and healthy new year.
Thank you so much, Susie. Just a final point, there continue to be questions coming in, so I think I may well take those and create a podcast. So we don't want to let these questions slide, and this is a great opportunity for you to get some answers to these questions. So thank you for your very active participation this evening. And as Susie said, enjoy the rest of your evening.